Manoj, since you are here.
Yeah.
Manoj, can you demonstrate? Let's get that out of the way. Since you started demonstrating, can we look at the SCTL on the back?
one more, Prof.
and then we get you.
Yeah, that's okay. That's fine. Okay. Before I get to the paraspinal, I want to spend a little moment on the brachial plexus anatomy. The previous speakers, they did an excellent job, but I think I can add a few more pearls in it. You heard the term sandwich, did you? Okay, I will remove that myth, okay? There is no sandwich there. Two is, often when you look at the interscalene groove, the aim is not to inject between the roots. Now, you will hear people saying, the roots, the roots, the roots. But they are the roots of the brachial plexus. They are not the cervical nerve roots. Make sense to you? Because the cervical nerve root gives off a ventral and a dorsal rami. What you are seeing are the ventral ramus. So I think the terminology roots should be removed. We should be more objective, talk them as C5 ventral ramus, C6 ventral ramus, T1 ventral ramus. Okay, so this is it. Now, I want to show you the sequence. And I think the speaker there, when he talked about SETB, he talked in length. And I think I would give him 9 out of 10 because he was just sounding like me in my paper. Yeah. But there are certain things he also missed out. But I think there is always something you miss out. But I think these are pearls that you'll find along the way. Now, if some of you here are beginners in scanning, if any neurologist here, that's also most welcome. Because we are teaching the neurologist or rheumatologist how to perform scan of the brachial plexus. It's interesting in our centers. So we have gained so much experience in this field that others are saying, in the past they used to say, oh, these are anesthesiologists, what do they know about ultrasound? Even I hear some discussion going on here with the government of Malaysia and so on and so forth. Very soon, you will be recognized for your specialization. So what I need to do here is, we are going to do like my suit, I don't wear a suit today. Normally I don't wear a suit, but when I do scanning, I'm very systematic. So I think I like to highlight that to you. So this is a high frequency linear transducer. We have, can we put it on picture-in-picture, please? If it's possible. No, not for you. The person over there, IT. So for this demonstration, the orientation marker will represent lateral, okay? If it's a transverse scan. It will represent cranial if it is a sagittal scan. Are you connected to the video system? Okay, good. Okay, so here, if you may just, okay, I'm going to place the transducer in the supraclavicular fossa. Can I have a little bit more gel? What you see in the image sometimes is what's between your ears. What I mean is you have to know how to optimize the image. So don't, I always say this, that don't look at the ultrasound image as a DSLR camera as this gentleman is carrying around. He puts it on, he puts it in automatic, it gives you a crisp, clean picture. Of course, he has a lot of skills, which he doesn't tell us when he uses manual focus, etc. Similarly, don't look at the ultrasound image as a DSLR camera. It is more complicated than that. Okay, so now can you reduce the depth for me, please? A little bit more? Okay. You can see the focus a little bit higher up. Okay, what frequency are we using? Listen to whatever I'm saying, okay?
17.
17? Can you reduce that a little bit? 15 maybe? Yeah, that's perfect. What map are you using? Can you change the map a little bit? The gray map? No. Yeah, no, there, go back again. So you see, what the map does is, like you have hi-fi systems in your home, right? It says rock music, stadium, football, something like that, right? It optimizes the sound immediately for you. So here, the ultrasound image is also optimized based on certain preset the factory has delivered to you. So make use of it, because rather than just using the gain button to go up and down, you have a lot of, I haven't even touched the gain button, you see. So this is to give you an idea that it is something that you always should consider, which is your here, yes, okay. I'm going to reduce the overall gain actually. Okay, now, okay, I think I'm quite happy with what I see in the supraclavicular fossa. Now I'm going to sweep the transducer. If you look, maybe you can focus here, please. The motion is basically a sweeping motion, okay? In the olden days when we had kings and queens in Malaya, in Singapore and other places, there used to be somebody sitting in one corner, pulling the rope, you know? And the thing would go like so. Think about that. So we are going to sweep the transducer in a craniocaudal direction, okay? Hoping to identify the individual elements of the brachial plexus. Now the typical sonomorphology, as we highlighted, is first is you look for the transverse process of C7, okay? Oops. They always say when you come to a demonstration, you don't see what you normally see. Okay, so this is the supraclavicular fossa where you can see the elements, I say elements of the brachial plexus are superior and lateral to the, by the time we return, I will tell you which each one of these grapes are, okay? I hope so. Now we are going to go up till we look for the C7. So where is it? Can you, I think we need to increase the depth a little bit. Now, it's been a while since I've been sweeping, right? Before I got to the C7, because he has a very nice long neck. And this is a volunteer that you should see all that I want to show you. A long-necked individual has a lot of space for the nerves to go and join and do whatever they have to do, okay? So this is the posterior tubercle of the C7. Can you see that? It's the bone, so there's a shadow. There's an acoustic shadow. You can use the arrow if you help me, please. Yeah. Just use the trackball. Use the trackball. Cursor, the cursor. Yeah. This is the posterior tubercle of C7. The anterior tubercle is missing. The C7 ventral ramus should lie just anterior to it with the vertebral artery there. And you have seen many videos of the Doppler. In the interest of time, I'm going to sweep further up. You see the C6 ventral ramus is coming out of the anterior tubercle is much larger. Can you see that? See the anterior tubercle there? This is the Chesniak's tubercle. So you already found out that the C6 and C7 are very easy to identify, okay? Once you have identified C6, now we are going towards the C6 ventral ramus. Look, the C5 is the smallest of the three ventral ramus, 5, 6, 7. So if you look at the circumference or the diameter, the C5 is the smallest, and this is the C5 transverse process, and you can see the C5 is emerging from that. It's the smaller of the C5, 6, and 7. Now I'm going to sweep the transducer distally now, okay? You cannot see everything, so focus on the C5. Your vision, I want you to see only C5. Don't look at anything else. The C5, okay, I'm sweeping caudally. See, the C6 has emerged. Now, can you freeze that for me, please? Now, do you see what I see between the C5 and C6? This is an intramuscular band, okay, that bridges between the scalenus anterior and the medius. This is well known, described anatomy, but we still today, no disrespect to anybody, we still describe it, we write about it, that this is a sandwich. Actually, there's not a sandwich there, see? The C5 is separate from the C6. And there are many intramuscular bridges that you will see as you go from proximal to distal, okay? And let's go again. So I go back to C5. C5, you see the bridge there, C6. The C6 transverse process you can see. Now the C5, you can also see the phrenic nerve is on top of the scalenus anterior muscle like a rat. See, it's there under the prevertebral fascia, see? Okay, can you see? I can see there. Okay, so here you go. Now The C5 and C6 will fuse to form the superior trunk. It's a much larger superior trunk, okay? Can you see now? Okay? All right? You see, this is the superior trunk here. In fact, you can see the C6 is bifid. Okay, this is because of intra-root splitting. Now, you are seeing three elements. They are not C5, 6, 7. They are C5, C6, C6. Okay? And this is indeed, in this young man, this will be where the superior trunk is located. The element that you see just distal to it, can you use the TGC to just bump up the signal where the arrow is? Yeah, just over here. Just a little bit. Where the middle trunk is. Yeah, okay. So now, you see the superior trunk and the C7 is now become the middle trunk, okay? Because C7 continues as the middle trunk. Now, this is an important neural stack again. I often say that you see the superior trunk, middle trunk, which is just below that, yes, and the C8 is just underneath that, see, yeah? Freeze that for me, please. Now, what you see on top of the C8 is another big intramuscular band, okay? This may be the scalenus minimus muscle. It emerges from the C7 and C8, C7 transverse process. But this neural stack formed by the superior trunk, middle trunk, and the C8 is a consistent anatomical landmark. It means you will not see the three trunks stacked up one against the other. It's always C8. So superior trunk, middle trunk, and C8. Okay? So this is the third important sonomorphological feature. Let's go back. So I go back to C5 again, just to continue the process. C5, C6, and then the C5 and 6 form the superior trunk. The middle trunk is the C7 becomes the middle trunk over there. And now, C8 is under there, right? You can see the neural stack of C8. It's because there is stacked up ones against each other, there is attenuation of the signal, so it appears dark, but it's actually over there. You can see it very clearly. Now, I'd like you to focus on the superior trunk. I want to show you the spar arrangement, the trifurcation of the superior trunk in the suprascapular, posterior, and anterior division. So, I'm going to just slide a little caudally, okay? So the suprascapular nerve is one of the first early fascicles that comes out from the lateral aspect. There we go. Can you see three nerves now? S, P, A, okay? So this is very consistent and it repeats itself from individual to individual. But if you look at anatomy textbook, they always describe it as SAP. So this anatomical diagram described as early as by Vesalius in Gray's Anatomy has been challenged, so much so that sonographically it is actually SPA, not SAP. Now this is important, not for us maybe, because we don't want to do a selective posterior division block, maybe in the future. But today we want to block superior trunk, not selectively posterior division, but sometimes you block the suprascapular nerve. Okay, so what you see below the SPA is the middle trunk. Okay, now the middle trunk is also divided. You can see there are two divisions in it. Okay, now the C8 I told you is the structure that lives on top of the first rib, transverse process complex. Now if I slide the transducer more caudally, I want you to see what happens to C8. Follow the C8. C8 there, okay? Follow the C8, okay? It's coming, the T1 will come from underneath. See, the T1 is where the arrow is now. The T1 will come, it go around, and it will join the C8 to form the inferior trunk. Can you see the inferior trunk now? That is the inferior trunk. So, ladies and gentlemen, that is the inferior trunk. So what you see on the top is the S, more lateral, more left, more left, more left. That's the suprascapular nerve laterally. Yes. Okay, the two on the top are the P and A. Okay, the P, yes, and A, okay? And the one in the middle is the two divisions of the middle trunk. Okay, so if you freeze that. So I hope the next myth, you will not go home and say, this is a bunch of grapes. Then I might say it's a bunch of, okay? So if you practice this, you do it on him, he do it on you. And after 10 scans, you become very proficient in this. And it's very consistent. It is a very reliable technique, and you can do it as we are doing more of this, we should be more like clinicians.